I actually sometimes am the first person where they're processing their birth.
I don't think a lot of OTs recognize that they're a recognized mental health provider.
Can you imagine pushing for an hour and a half and your baby is not progressing?
I train husbands all the times. I train moms all the times, grandmas all the time.
This whole mental health process that you get when people are explaining the birth story. Most people aren't walking around talking about, oh, I'm leaking all the time. My bowels are messed up. I can't hold in gas.
For you, if you got the spidey senses are tingling, you have a gut feeling, something may be going on, even though this person may be saying otherwise, screen them and then start making the recommendations.
And when people find out, oh, I'm not the only person experiencing this, again, it helps them with their mental health.
Like, hey, if you guys are seeing any of these things, this is a warning sign. Here's what we need to do, especially as it relates to maternal mental health.
I'm 23 and I'm going to always have to have a diaper on. Great.
As we were saying, I want to pick up right from the conversation that we were just having. So the heat is not in Dallas, Texas. It's everywhere else. Is that right, Dr. Brown?
Everywhere else. As of right now.
This heat is crazy. These 98-degree days, you come outside and you already feel defeated. Look, you could be in a room with AC, you step out the door, you feel defeated. You have lost the war, okay? You have lost everything because it is so hot.
Wait, I'm confused. How is Dallas, Texas not as hot as Atlanta, where
like I
Dr.
said,
Martin, where you are?
Global warming is real. Climate change is real because normally we're hot. Granted, we're entering into the first week of whenever between now and August 13th tends to be our hottest time of the summer. But by this time, we're normally hitting 100 degrees consistently. We've had 1.5 weeks of 100 plus 98, but it's for the most part, like right now I have overcast and we have rain. So
we've had rain in the last few days, so it's been a little bit cooler. We might have had a day where it was in the 80s, like high 80s, but
we've had several in the 80s now. So yeah.
Several in the 80s in Dallas, Texas. I just can't believe it. I can't. I'm thinking like, okay, Colorado is a little bit warmer than, usual maybe, but Dallas, yeah. That's all right.
It's really unusual. I'm not complaining. I'm not, but yeah.
No, enjoy it. Enjoy it. Wow. So I have the founders of Pelvic PT Doulas, and I want to jump right into this. Why did you create that program?
So I remember we were having a conversation during COVID, and we were at that time, doulas weren't being allowed into the hospital. Like there were a lot of places where, doulas weren't being allowed. People were having to birth by themselves, all those types of things. And we were talking about it and we're like, well, PT's already in the hospital, and what better person to, to advocate for birth, because we already, especially, if it's a pelvic PT, you already know this anatomy. You already have a baseline understanding of like some of the medical aspects of it. And we're in the hospital. So if, that's a shoo-in right there. And I think that was a huge start for us. But then along the way, we recognized that not only from our own practices, but just from the feedback that we were getting, is the way that the program has positively impacted other people's clinical reasoning skills, their ability to educate, all those types of things, their ability to then help people going into, deliveries, even if they themselves aren't there, but the ability for them to educate them in such a way that then on the backside of that, when they're coming back postpartum, we're not seeing a lot of the things that we probably otherwise would see, with a lot of these patients. So.
And we both went through a doula training together, and we just realized the material that was being provided, I guess I should say, from the organization wasn't where we as PTs need to be. Like there was a lot of things that we were like, oh, we actually know this. We actually know this. We've been doing this. We just didn't put in like a nice pretty bow to like serve it on the plate. So we were like, well, you know what? We could add a couple more things because childbirth education isn't huge. Like I teach it into my entry level PT classes, but it's not enough that if I graduated from PT school, I would have remembered all the details. And so that was that was another component that we felt was missing in general pelvic PT, that we will help people with prenatal, we'll help them with postpartum, but the actual birth component and understanding the birth and like all the steps that takes, it changed my practice. I mean, residency train, I was helping people prenatal, but it changed from me being in that doula space and actually witnessing the births where I was like, oh, this is what I need to be able to do. And it has definitely changed the outcome of my clients, both my doula clients as well as my PT clients. And so we definitely said that we need to make sure we had an impact in that way, make a
So,
difference.
but so with Dr. Martin, what you said initially, that PTs were already in the hospital. We weren't on labor and delivery units though. Like we are
So
on the back end.
we're on the back end, but here's the thing. They're already in the hospital. They already have a familiarity with the hospital. And I think in a way that the layperson because the average doula is a layperson. Every now and again, you'll find a doula who has training as a nurse. I've had doulas notice doulas in other trainings I've done who have been nurses, PAs. I've had a physician in a doula training, things like that. But that is not the norm. The norm is usually you're having lay people, many of whom have no medical knowledge whatsoever. So if we're in a situation where we have people who are not, who, have no hospital knowledge. And we do have people that do, right? One that has the access, because, I mean, for one, if they're not letting other people into the hospital, right? Now, could this be an opportunity? And I guess, and I think the way we were thinking of it, now this is an opportunity. The hospital doesn't have to feel threatened, right? Because it's one of their own. Even if this person is saying, you know what, I'm going to come alongside these moms as a separate entity, but I already am known here, right? And it gives people a little bit more autonomy. Going through COVID, a lot of people were losing their jobs. Listen, if you have an extra income stream, there you go. So for some people, it was an idea, it was an opportunity for that. But what we were thinking is we've already got boots on the ground, so to speak. We've already got people in the hospital. We can channel them. You got PTs and outpatient, or who cross between outpatient and inpatient. They're already seeing the women when they're pregnant. They're already seeing them postpartum. Let's go ahead and do the training and kind of bring them into that setting so that we are having people supported, right? Because again, I have a really good friend that says business is numbers, everything else is drama. But when you're looking at the hospitals and whatever they were going through, if we can help people, we can improve outcomes. Like, who doesn't want that? We could save some money, right? Because hospital is still more often than not a for-profit institution. They're still trying to make some money. So if we can address all those things, why not?
Yeah, for sure. And Dr. Martin, you and I have talked about this extensively, but Dr. Brown, I don't know if I told you this, but it was around that time, 2020, 2021, where a lot of hospitals across the board, because of COVID, were having those restrictions. Families could either have like the one person that they wanted by their side, maybe two at the most. And so if it was a mother's own mother and her partner, that was it. There was no doula by her side.
Right.
She had to pick the two people that she could have, or one person in some cases. And so I met a doula around this time that created this coalition with the help of larger entities. I mean, it was something I had never heard of in the state of Colorado, where she started a program that then was able to bring doula services into the hospital, to where I think now they've grown to where the hospital now pays those doulas and reimburses them for their time. So root efforts like that were spurred on by COVID. But in your cases, you were primarily intent on teaching rehab professionals, not lay people, which we know, like you said, Dr. Martin, lay people are taking doula courses. Health providers like physicians. There was a lawyer in my course, a childbirth attorney in my course that wanted to get the other side of the issue, because she had been primarily advocating or defending the hospitals in cases, right? In maternal injury cases. So she wanted the other side. And so, in your standpoint, rehab professionals, you explained why you were targeting them. They were already in the hospital. They already had this like, interface with clients during pregnancy. So why not bring their services into the hospital, right? Where my question asks, and this is probably a big one, and we talked about this a little bit before we came on, is in that doula role, do those clinicians take off their clinician hat? Do they stop being a doctor in the doula role? Do they stop being, a rehab professional, and now they are a support person when they're in the hospital with their clients? What do you teach?
I mean, so we do teach a separation of the entities, because if I'm going in there as a doula, I'm a doula. I'm working for this client. I am, providing that physical, emotional, educational, advocacy support for this individual. However, my brain never stops working, right? I know, when I see certain things, especially medically, what they are, because I've got that background knowledge. Now, that helps me to better educate them. That helps me to better advocate for them. That helps me to have better dialogue and discussion with the other health professionals in the room. But I think, it's realistically what we tell people is, because there's also been situations where doulas have been kicked out of rooms, because again, doulas are on the side of less medicalization. And sometimes, there have been situations where many have gone in kind of, so to speak, with a chip on their shoulder. You can get a lot more with honey than you can with vinegar. So we teach on the side of, when you go in, your job first and foremost, even though you're working for the client, is build rapport, because they know who you are. And it's not like my clients don't call me Dr. J. So then I get this look like, huh? And it's not like my name badge that I wear and doesn't say Dr. Juan Martin, doula and physical therapist, with all my information and all the credentials on there. So they see it. And then I can ask pertinent questions. I am not in there necessarily, giving medical advice, but I can have good dialogue with the providers and even with the client when it comes to things like positioning, because we do know that as physical therapists, we are the musculoskeletal experts. And so when it comes to things like, maybe I had a client who I was seeing during pregnancy who also might have been needing some and the nurse is maybe saying, well, I need you on your back, but they're not, they're not going to tolerate that well. I can have a conversation and say, hey, I've been seeing this client during the pregnancy as well clinically, because she's been dealing with these types of issues, and having her on her back is going to exacerbate, or it's been historically exacerbating that pain. Could we augment this position in some way, in a way that allows you to do what you need to do if there's anything that they needed, but also makes them more comfortable? Because the last thing we want is for her to be in pain and cortisol levels to be rising and labor to be kind of slowing down. Like, we want things to progress nice and steadily. So with that, you can have those conversations. So to answer your question, do we shut it all the way off? No, but when we do go in there, we are acting as a separate entity from our clinical role.
Yeah, I want to ask you both, and Dr. Brown, I'll start with you. Have you guys heard of Gina Mundy? And she is a childbirth attorney, in the role I was speaking to of before, of the attorney that I took a doula course with through DONA. But she's a childbirth attorney that primarily also advocates on the side of the hospital. And she said something in an interview that I'll be releasing soon that like put me aback. And this is the part, Dr. Brown, that I said I shared with Dr. Martin plenty of times as to why I created the program that we created to train primarily acute care therapists in the hospital already, very similar to your work. But she said that in terms of her role, she does not defend mothers and families directly. She defends the hospital. But she's written a book recently for the families to know that when it comes to cytotec or misoprostol, and when it comes to Pitocin, try to avoid those unless they are in life-threatening situations, unless it's absolutely necessary, and avoid those two medications specifically for the purposes of induction. Up until this point, I had never really heard anyone say that out loud. It's always the quiet parts, right, that we're tiptoeing about. But she said the quiet part out loud. And as a physical therapist in the acute care setting, I was seeing and tracking on my own Excel spreadsheet while I was working at a hospital all of the primary cesarean sections that would start off with Pitocin and Cytotec. And I never felt comfortable, even in teaching in my own program, what my theory was about those medications. And so I often wondered, as a doula, would I inform my patients differently? Or as a physical therapist, would I speak up? I mean, I still don't know the answer. And so I want to just ask you very just candidly, are there medications in pharmacology and labor and delivery interventions where you speak up a lot louder when you are training your clients directly? And how do you train therapists to navigate those medical interventions used in labor and delivery?
I wouldn't exactly say there are certain ones I speak out about louder, but I do make sure that I always tell people be a toddler. Why? Why are we asking to be induced? What is the need? Is there an actual medical reason for this? Or are you just tired? Again, I'm in Texas. People, when typical summer, it gets hot. You're going to be tired of your pregnancy. You're going to hear the words, we might look for induction. Okay, well, ask your provider, what does the induction look like with them? Because every provider is different. Every kind of, tools that they may use, any kind of medication. I make sure make sure they guide that, because I don't want to just do a water hose of, well, avoid all these medications and come to find out the provider doesn't even use that medication. So I make sure they do the legwork of understanding what is the procedure, how does it look, and then I provide them with the resources. I will never tell them don't use it, but I'll also make sure they understand the process of an induction, the intensity of an induction, the cascade of interventions that may follow because of an induction. And then that way they're able to make an informed decision. But do I personally tell them avoid that at all costs? No. Only because if their provider says this is the only medication I use and they end up using it, now they're stressed because I just told them all the side effects that could possibly happen. But we're trying to help with the progression of labor. It's kind of like if you listen to, Pepto-Bismol, they have their commercial, and at the very end, they do like the cute little dance, like heartburn, upset stomach, all that stuff. At the very end, they go down the whole list of all their side effects, and then you hear death. Well, if we all heard death, we would never take Pepto, but I know plenty of people who have the pink stuff around, right? So I kind of leave that around when it comes to the medication with labor and delivery. Because just as I've heard of bad outcomes, I've seen plenty of good ones, but with informed decision making. So I don't know if I answer your question clearly, whereas like I provide them with the resources, but I want them to make sure that they guide, they're the leaders in understanding. Is your job to understand what is your provider's technique for their actual induction, and then I can provide you with the appropriate resources.
No, that's an excellent answer. And I want to pass it to you, Dr. Martin. So Dr. Brown, thank you so much for using like Pepto-Bismol or any of the pharmacology commercials that we see, right? I mean, US is one of two countries in the world that really have full reign when it comes to direct marketing of pharmaceuticals to the public, right? New Zealand is the second. And so with that caveat that you're talking about, when you're going through pharmacology or interventions or just anything globally, who does on the birth team take the time to even go through those side effects though that we all really need to know? Like we do hear that stuff on the commercials because they're obliged or they have to tell us, right? But in your experience, have you found that patients are informed of those side effects to the full extent that they would be when direct advertising from the pharmaceutical companies do that? Do you find that that's the doula's role? Is that the health provider's role that's actually prescribing those medications? Or could that be our role, a combination of a pelvic PT or occupational therapist, doula trained provider?
I think part of it, like Dr. Amber said, it comes down to the way that we educate clients as a doula and really helping them to be informed. We don't wait until they're 39 weeks and the doctor says you're going to be induced to start having them ask these questions. We start having them ask these questions. I for sure, and I know Dr. Amber does, start asking these questions early, second trimester, right? Because you want to have conversations with your provider. What happens if I go over 40 weeks? Like a lot of the common reasons for induction, people are going to say, well, you're over 35. I know many healthy 40-year-olds who move way easier and better than 20-year-olds. I know many 40-year-olds without health conditions. And so rather than looking at individuals on a one-on-one basis, some doctors will, but there are many doctors who won't, and they will paint everyone with the same broad brush. And so you are 35, you are advanced maternal age, we will induce you. This person can have a completely uneventful pregnancy, completely uneventful. And so for no other reason, no medical necessity. And if we look at ACOG guidelines, ACOG specifically states that induction is only warranted if there is medical necessity. And so what tends to happen is that we will have situations where we're having inductions without medical necessity. There are also some of the other reasons, like, well, if you want me to be your provider, then we got to have this baby on this day because I'm out of town next week, or I'm not on call this weekend, those types of things. And so again, questions that you want to ask your providers, my due date is September, whatever, let's say September 1st. Let's say Labor Day was September 2nd. My due date is September 2nd, or September 1st. Labor Day is the next day. Will you be here? Will you allow me to go to my due date? Because I've had clients who, for no other reason than a provider saying, yeah, I'll be there with you, I'll be there with you, I'll be there with you. And then at the 36-week appointment, we got to induce you. Not because there was a medical issue, but because the provider is like, well, I'm going to be out of town, I got plans. I've had someone been told that. So when it comes to those things, we have them ask questions early. As far as the specific medication, I think it's important, like Dr. Amber said, to educate them about what the options are. And even to start engaging in those conversations early. If I did, in fact, need to be induced, what might that look like? What could that look like? What is typical for you? So that they can start making their own decisions based on the information they're receiving in a time of calm, in a time that they're not under duress. Because when they're in the hospital, and the nurse is telling them, hey, we're going to give you this, you're going to feel a little burning, go ahead and sign the sheet. But the sheet has all of the other information, like, this may happen in the event that these things are happening, the hospital is not liable. The nurse is not spewing all that stuff out, because that person is going to probably hear one of every 10 words, right? They're not hearing half of what is being said. You're going to feel a little burning, you might feel some numbness, this may happen, that may happen, and they're reading it. Sometimes they literally sound like the same commercials where, yay, Pepto-Bismol, side effects may include, that's what it sounds like. Nobody is cognitively processing all of this stuff. So again, we don't want to wait until they're under duress. We want to make sure that they're aware and educated well before, so that they can make those decisions, so that their partners, their family members can make those decisions. We want to help them be able to better advocate as necessary when it comes to those things. And Cytotec isn't used in a lot of places. I believe France had banned it a long time ago. There are a lot of European countries that have banned it and do not use it for the process of induction. The US, we're a little different. I mean, we eat things that other countries don't eat. We're still around here slinging red dye, blue dye, yellow dye, and every other color in between, but
And I just wanted to piggyback off of that, as far as even when we have that discussion about, is your provider going to be available, your estimated due date? And I say this because we have that discussion of, okay, if they're not available, what does that mean to you? Because if you already have your mind set up that you're going to be induced so that you can have, your provider at your birth, this is our plan. This is how we address this. Versus, no, I'll be okay. I'll go with whoever's on call. This is our plan. So that's part of us being the doulas, where we're helping them with the coaching, helping them guide what direction that they want to go, but we're able to actually educate them. Because I can't tell you how many times I'll tell people earlier on, first try, second try, like, hey, you're going to get to week 36, 37. You're going to be over your pregnancy. You're going to start hearing some things possibly about your baby's head is big. Your baby is, 2 or 3 weeks ahead of schedule. I'm saying these things now because you're going to be like, oh, that's not going to happen. But when that does come up, I can remember or remind them, sorry, about remember that discussion we had earlier on? This is that moment. And this was your decision. This was your plan before that you said how you wanted to proceed. How do you feel currently? So that's the good part about us. Again, we know we're medical providers. We're well aware of how the medical system works. And so we are able to actually work within the system to prepare our clients in a different way because we are part of the system. We know the backside of the system. And that's kind of our way of kind of doing the whole, you know, taking a big knock at the system, like we understand it. And we're going to be able to help our clients navigate it in a different way because we are part of that system.
I've been waiting to have a conversation with you two for a long time, because there's been a question now that Dr. Martin, you've spoken publicly, um, really about like your training to the audience that usually follows my work in terms of like preparing those acute care therapists to serve on the maternity unit. You've made it quite clear that there is a distinction between pelvic PT doulas and the training program that you all have created and enhanced recovery after delivery. And I've been trying to articulate it well, but there was something that you said that made me think, this would be a perfect opportunity in our interview just to make sure that that is really clear again. And I think I could probably speak to it from my standpoint in that 2021, we encountered a mother that you would not think would be a high risk postpartum patient because of her Caucasian ethnicity. I mean, she in terms of just the risk factors, we know that being Black in America is a risk factor when you're giving birth. And someone from our program evaluated her, sent her home. It was kind of determined it was a low complex, no further needs for physical therapy type of situation where she was being seen after cesarean section. Within 12 hours, this individual came back to the hospital with a brain bleed, massive stroke, and needed burr holes through her skull to drain out the fluid and the pressure. She was in the ICU for 9 days. And we've spoken about this publicly at CSM since then. And I started to really think that a lot of the barriers of enhanced recovery after delivery was that we were working with professionals who had time constraints, as already acute care therapists do. And Dr. Martin, from your experience as a NICU therapist, you know this very well, that productivity is primarily a number one concern and a barrier for therapists to even think that the maternal population is a priority. If they're up and walking, they're fine. That's the assessment. That's where the extent of assessment from a physical therapy standpoint. I cannot speak to occupational therapists, but from acute care physical therapy, that priority is really gauged on their function of walking. And so that being said, I started to really think as a course creator, director of this program, that my barrier would be the individual therapists and their training. Is that I knew I couldn't provide them with the skills and almost that value that you have to come to this program with in terms of valuing and prioritizing someone's health and well-being over the stipulations of your hospital if you're being employed. And I came across your work probably too late into already creating my program and understanding, oh no, you're training professionals to work directly for the client, not their hospital systems. Here's the distinction. And so I'd like to just have you both kind of round out this discussion as we close to really help therapists understand the value and the benefit of taking a training like pelvic PT doulas, because I see the future is bright. The horizon is clear. Every provider, even if they're going through my program or not, needs to take this type of training. needs to have that know-how of labor and delivery medicine, because we're not really truly preparing them to have those internal values from the start. You are. Can you speak more to that, to just the program and just who is a best fit for?
So we usually work with clinicians, PTs, OTs, PTAs, CODAs. What I would say is this: for most clinical programs, we're looking at, maybe, oh, let's look at their vitals, let's look at there's some sort of metric that they're looking at, there's some sort of range. Even with that, I tell people, here's the thing with lab values. If you fall between X and Y, and Y is the high end, and we are on the higher side of normal, most people are going to be like, oh, but they're still normal. No. What we look at as doulas when we are helping a patient is to say, we're on the higher side of normal. Why? Because we also know that that could be a warning sign. When we're looking at our clients, we are not only educating our clients about how, what red flags are, helping their family to understand and identify red flags, not just physiologically, but psychologically, right? Because we don't talk about mental health. It's getting more playtime, but we oftentimes don't talk about it enough within certain cultures, communities, all the things, even here within the United States. But the other thing that we look at is, because we are working specifically in the intrapartum period, we are teaching these clinicians about what the expectations are based on what is happening during labor. So again, you could have someone that comes in, you come into a room, they're up at the side of the bed, they lay down, they transfer to standing, and for the most part, right, the average PT is going to see that and go, they're good, fastest eval ever, right? I can meet my productivity goals. I'm asking them, tell me about your birth. I'm checking their vital signs. I'm also looking at any labs, any tests that have been done. I'm asking them how they feel, because I also want to check for things like POTS, orthostatic hypotension issues, all those things. I'm looking at radicular signs and concern, radicular symptoms, because if they're telling me they had an epidural, well, how are we feeling? And most people might think, oh, well, the epidural is just, oh, well, they might have some lingering numbness, tingling, or whatever in their legs. I want to know about your bowel and bladder function. Are we having urinary hesitancy? Because you also have that catheter placed. There are a lot of different things that we are looking at that are just outside of what we initially might see, right? And we're also helping them to be prepared. Here's what's happening right now. Here's how we look. However, if any of these things come up, if you are feeling any of these things, let us know. The other thing is, we all know as clinicians, most people brush things off. New moms especially will brush things off. Are you hurting? It's not so bad. Meanwhile, it's an 8 out of 10, right? Something is, like an arm is falling off. It's not so bad. I feel okay. The baby needs to be nursed. Well, let's take care of that first, right? And so they don't necessarily prioritize themselves. You have to give the patient permission to prioritize themselves, because in doing so, what you recognize is you learn a lot more about them than you otherwise would. That little bit of, blurred vision that they don't think is anything is a warning sign for us, right? Well, I feel fine, but when I go sit down on the toilet, like my urine is not coming out, is a warning sign for us. They might not think anything about it, because in their mind, well, I just had a baby. I'm just tired. I haven't slept. 1,000,001 people have come in here because the hospital is the worst place to get some rest, actually, all these things. So they're not necessarily thinking about these things. So we have to, and we have to be thorough. And it might mean that it might still be nothing, but it is up to us to be thorough. And those are the things that we also talk to our clinicians about when we're training them. You may be in there as the doula, but you're also monitoring them in those first couple of hours postpartum, right? You're still monitoring. You're educating the family, reminding the family, here are some things I want you to be mindful of. we're still making sure that the people close to them know, so that they can continue to advocate as needed.
Dr. Brown, but I want you to kind of drop a little bit more of your background, because you have said publicly, and we've spoken at CSM, just based on what Dr. Martin was talking about, a lot of that is also just mitigating risk. However, you have highlighted for me in the past that we also just need to stop infusing mayhem and death in perinatal care. Like, maybe that it is okay, which my program doesn't speak to, because we're teaching a lot of hospital trained therapists that to start programs, they have to prove a need. And to prove a need is the same concept of putting up a traffic signal. We have to prove that there's been accidents. We have to prove that there's been death. We have to prove there's some value and benefit to what we're doing. But you have spoken to, why not also just speak about the positive, about the benefits, about the, all of these things that, doesn't put pregnancy and postpartum period in this medicalized state. It's natural, and it's natural to have a successful birth experience. So can you round out that part of the conversation, and end with that? Like, what do you want clinicians to also just take away, especially if they've received pushback from their hospitals to even provide these services, but they know deep down in their heart, they want to serve those clients and they want them to have a really positive experience and never even encounter the things that Dr. Martin was talking about?
And I'm coming from like the outpatient perspective of everything, where I'm seeing people, of course, as a doula, within the first 24 hours, I'm there by their side postpartum. I'm able to speak a certain language that when I'm leaving, I'm able to speak with the nurses, but then also I notify the family, like, hey, if you start noticing these things, normally I'm speaking with their support person, whether it's their significant other or a family member. Well, I'll remind them, if you start noticing any changes, reach out to me. I'll help you with navigating what to say to the nurses who are there with you. But by the time they come to see me at outpatient, whether it's 2 weeks, but I'm still, communicating with them, or whether it's 6 weeks, the difference is that I cannot tell you how many people have been so happy with the experience of their pregnancy and birth and postpartum, that they're not having to, talking about medicalizing it, they're not having to come see me because they're healing something. They might come see me so they know how to properly recover, meaning like, oh, this is how I properly engage here, this is how I lift, but it's not because they're coming in with a deficit, if you will, which is what we normally I'm all about being proactive. What can we do now so that 10 years from now, 15 years from now, we're not experiencing leakage. We're not experiencing, oh, now you're going through menopause and our hormones are changing, but we never addressed anything immediately postpartum. And now we have to be reactive to things. And so I think that's part of how we medicalize birth is like, well, what's wrong with you? Oh, you're not having back pain. You don't need PT. Yes, they do. Yes, they have a whole human that's going to come out of them one way or the other. And their bodies are changing in so many different ways, which is a miracle and it's a beautiful thing. But we have to understand birth is a lot on our bodies. We would never have someone have shoulder surgery, whether it's rotator cuff repair or total knee replacement, and be like, you're good. No, we know how to be proactive with that. Oh, your knee hurts. Well, let's try to do some prehab first, see if that helps a little bit. Go have surgery and automatically have rehab. When it comes to birth, congrats, you're pregnant. Go see your PT. They're going to do an assessment of your body. Oh, you fell while playing volleyball 10 years ago and you had a little injury, like your pelvis is a little malaligned. You didn't even know it. But you know what? Your PT was able to assess it and help you with that alignment before that pain started kicking in. And little things like that is how we make sure we're not medicalizing pregnancy, birth, and postpartum. We're just helping along with the journey. We're being proactive, helping with wellness. So I think that sometimes we need to kind of take our hats off, but keep them on where we are aware, oh, you're having some blood pressure issues, your balance is kind of off. Just little things that we could think of. Now you're having pain, you're kind of moving a little differently. We know how to medicalize it, but let's start with wellness. Because then when the PTs are in an outpatient world, we know how to speak the language to the PTs in acute care. Hey, I wrote up this little note. that you could give to your support person. And this is speaking to those who aren't going to be a doula, who are not going to be there at birth, but you're still by their side during pregnancy. You saw the things, you saw what was happening during pregnancy. Write up that note that you would normally write up whenever you're going to go on vacation and you're handing off your patients to someone covering you. You say, oh, Mrs. Jones normally likes her exercises like this. We're used to communication. We speak the same language. Write it up, give it to the partner, and tell them, hey, make sure that the PT who comes in to see you is able to kind of assess these things. Or better yet, for those of us in outpatient world who are working with people prenatal, have them ask, have them request a PT to come assess you. Like we are the forefront where we can actually, outpatient world, encourage this more by reminding them, hey, yeah, you want, the lactation consultant if they're there, if they're on duty. Also, you want to request an assessment of PT or OT before you discharge. Because what if someone had a C-section and now they're having to somehow support their baby while feeding them, but no one told them how to properly move, how to actually position themselves. Your patient doesn't know they need to ask that question. And if it's not a standard part of the hospital yet, that outpatient PT put it in their ear already saying, before your discharge, you need to have OT and or PT come assess you. And that's how we can help make sure we're working on that whole wellness component instead of waiting for now you'd have pain and you can't stand properly because no one told you from the very beginning that you need to be able to lie down flat to help with the healing of the scars. Let's skip that part. Let's skip that part and let's actually do some wellness and be proactive out here.
Wow. Yes. Thank you. I needed to have this audible so that this mic picks up these snaps. Dr. Amber Brown and Dr. Juan Martin, co-founders of Pelvic PT Doulas, a training program that prepares physical therapy and occupational therapy practitioners, including PTAs and OTs or CODAs, to properly and appropriately support families during pregnancy, labor and delivery, and postpartum recovery. I cannot thank you both enough for sharing your knowledge, your wealth of expertise, and for making your program accessible to rehab professionals. I understand that this recording will be shared and seen, even months and years from now, but it's still important for me to seed where people can find this program as it evolves. Is there a home that you really want people to focus on and go to? And are these programs run throughout the year? Can you just end the discussion with that? And thank you so much for your time.
Yep, if you go to the pelvicptdoulas.org, that has all of our information on there. You can, on that main page, you can just click on for doula training and that pulls it up. We run our doula trainings. They are a hybrid program, so all of the didactic information is online. And then we complement that with a 4-hour office hour session where we go through a review of all the information. We go through case studies and we talk about business and specifically trying to cater what their specific needs may be. Are they an acute care therapist? Are they an outpatient therapist? How are they looking to integrate this new training and level of education into their existing practice and the work that they're doing? So we do, it is hybrid. Like I said, we do those office hours every quarter. And yeah, we would love to have you in there.
Excellent. Thank you both.